So we'll get started, and just a quick reintroduction of ourselves. My name's Gerard Gianoli, and I'm joined with my co-host, Dr. Mohamed Hamid and Dr. Eugen Ionescu from France. And we are presenting monthly interesting vestibular cases. We're rotating the duties on that, and hopefully this will foster some interesting discussion. This month is going to be presented by Dr. Hamid, who's got a very interesting case of positional vertigo. And I have here, this is recurrent positional vertigo with a tragic outcome is the title
I'm
for it.
sharing the screen, so the screen actually is on my computer, Jerry.
All right, so I am going to
I
stop
think
sharing mine.
Gerard is not. It's
Let's see, I'm stop sharing. How's that? So yours should be able to be shared now, Mo. Is it coming up? Do y'all see his screen? There it
yes,
is.
but I think that is the screen of Gerard. There was a problem, Gerard.
No, I think that's Mo's. Isn't that yours,
Okay.
Mo?
Push the button, see if we can see the next screen, the next slide.
Yeah.
Yep,
Good.
that's it.
Good.
All right. All right, Jerry, thank you. I think this is becoming a more popular platform. So today we're going to talk. Most of you know who I am, so I'm not going to go into this. So this is a pediatric case that I thought really is important to share with meetings whenever I can. I saw this patient overseas, not in the United States, and it was in the Middle East area, so that because I'm going to come back to that later on. It's a 16-year-old with 1 year history of inability to ride his bike, slowly progressive, and feels clumsy, has a bit of headaches, no hearing loss. Now, I did not have the records from his prior evaluations. So this is coming from the patient and his family. He underwent several audio-vestibular testing evaluation and eventually was given the diagnosis, presumptive diagnosis, as we all know, of BPPV, sent to vestibular rehab for months, and no improvement. It's getting worse, if anything. So I want to kind of follow Jerry's idea about discussion, pause for a little discussion to the faculty. But please, audience can post the questions for answering them at the end of the webinar. So for my colleagues here, Jerry and Eugene, what's wrong with this story?
So for me, the fact that it is progressive despite vestibular rehab therapy tells me that we've got a progressive lesion of some sort. For the most part, I think of vestibular rehab therapy, you're trying to get the brain adjusted to some static lesion. And when it doesn't work, it implies that the lesion is not static. I guess the other two big sort of red flags for me on the history is his being clumsy, which, I mean, granted, you can certainly see that with patients who have, vestibular problems, but you also worry about other neurologic conditions. And the fact that he has headaches, which are not extremely common in 16-year-olds.
Okay.
And yes, thank you. For me, if the child he had no hereditary antecedents of migraine, it's very important to notice that this headache associated to no hearing loss. It's very important to think to a center of pathology. And I think that I think that we don't need to wait too long before demanding an MRI in these cases. And I saw in my ex life of neurosurgery, I saw very much children with huge tumors, but with minimum signs of hydrocephalia, especially when the tumoral process occurs in the posterior fossa.
Okay.
So I think that it's important to find out that there was not a problem, a central problem in this case.
But if we just take the symptoms, inability to ride bike and feeling clumsy and headache, why would I send a patient like this for vestibular rehab?
It is possible. Jerry was talking about red flags. One of the red flags with somebody who's not getting better is bilateral vestibular problems. So if it's been seen, if he's got nothing obviously neurological going on, it could be a bilateral vestibular problem. That would be one reason to send the patient to rehab. Not that they're going to get better, but it might help them and encourage them to keep active and try and get a handle, more of a handle on their history to see if they have any other vestibular sounding complaints, subtle nausea or motion sickness or anything like that. So that's
Okay.
another red flag.
Yeah, but I couldn't get my hands on any of his prior. I think he had about 6, 7, 8 vestibular tests and hearing tests, and reportedly were okay, but they pointed to positional vertigo.
And positional vertigo in children at 16 years old with no trauma, I think that it's very rare.
And it does not make you clumsy. Positional vertigo does
Yeah.
not make you clumsy.
Yeah,
Yeah.
I was going to reiterate Eugene's comment about getting an MRI scan. For the most part, I think anybody with new onset headaches, forget about everything else. I think they deserve an MRI scan.
Yeah.
But also add
right.
to that the clumsiness, the fact that he's had no ability to ride a bike and he's 16 years old. I mean, it'd be different if he was 86 years old, but 16 years old, that's just really more than
Concerning, that was a red flag.
traditional
Yeah.
vertigo.
Yeah.
All right. So patient comes in. When I go, I mean, there is kind of a visiting professor and patients are lined up and this and that. But I take my time getting the history and physical exam, or sometimes these need to be really done with no time limitation, in my opinion. But anyway, this young man was walking unsteady. You can tell. And here is the issue in general, and that's for even the junior physicians starting in the field. Your history and physical exam are the most two important components in vestibular medicine. You could tell that he has gaze-evoked nystagmus and distorted pursuit tracking, failure of fixation suppression. Just right off the bat, poor finger, nose, and random alternating movements. He had symmetrical VOR without, I kind of put the goggles on like what everybody does. Didn't have any post-head shake nystagmus, positional nystagmus, or BPPV. He's walking with poor wide base gait and diffused hyper deep tender reflexes. I don't use ophthalmoscope many times in my practice, but I looked on his optic disc. I couldn't see the margins, and that definitely was venous congestion as well. So to me, right off the bat, without seeing any of the prior tests, I thought this was definitely a cerebellar plus or minus elevated intracranial pressure. So what what do you, again, we're posing for discussion with the faculty. What do you think?
One question, Mohammed. Was there any complaints of visual loss or blurred vision or anything like that?
No, just the headaches and the clumsiness and inability. Definitely, this is a young man. He was a little slow in his speech. I mean, I really was very concerned about his appearance as a 16-year-old man walking to my office.
Well, for me,
no BPPV, and he has had, uh, you know, and that's a point that we really need to address a little bit more. That most physicians don't do that. It's sent to either physical therapy, or even patients nowadays go to physical therapy, and they keep doing it repeatedly, and that's a red flag by itself.
Sure. So for
So,
me, Mohammed, your exam just kind of screams, cerebellar dysfunction, and as
sure.
well as the possibility of elevated intracranial pressure. So you put the two together, it makes you wonder if you've got something that's some mass blocking CSF flow in the region of the midline cerebellum. Um, that would be the most obvious explanation.
Yeah.
I imagine
Eugene. So, sorry, Art. Yeah, we'll get back to you. Eugene,
Yeah.
what do you think?
Um, I maybe it's interesting to know the headache was predominantly in the morning or and the day long. It's because the ICP generally can generate headache in the morning, namely. And yes, of course, I think that in this case, the surgery should be performed.
Okay, I didn't ask that question, but that's a very good point. Yeah. All right. Art, you wanted to say something?
Well, I'm just going to say quickly, it's probably the lesion is probably lower if we're trying to locate it, probably lower down. If he doesn't have any VOR disruption or something, I'd look lower down. Again, not being a neurosurgeon, it looks like maybe like a fourth ventricle, like Jerry was saying, increased pressure, maybe a fourth ventricle lesion or something like that, blocking something. It must be something lower down. It's not affecting, doesn't seem to be affecting his MLF, except to the fact that his increased pressure is blurring his optic discs. So
Okay.
that's where I'd go from there.
and
Over to Dr. Ionescu.
I was just saying, one of the points that I was kind of starting to bring out is a lot of these folks will have optic disc edema and no complaints of visual loss, even though they may have pretty significant visual field cuts.
I don't know how many of the neurotologists actually use ophthalmoscope. I know
I use
few that would do that.
I do it. It's very good.
Yes, I know. All right. That's the MRI of the patient.
Yeah.
So, Jean, would you like to comment, and then Jerry, obviously.
Yes, the middle line processes and the subtentorial, obviously, which generate a slide dilatation of the ventricular system, but it's not very important. I don't think but it's obviously in the left and in sagittal plane where we see it's a huge tumoral. Yes, I don't have some. You do have some slides with injections? I don't know but it's a processus, midline processus in the posterior fossa, obviously.
Jerry?
I'm sorry.
And
I
I
mean,
think I would like to complete. I think that even in the hypovisceral low is a. I think that it's partial empty cella, but so sign of indirect signs of intracranial hyperpression and which could explain the headache and the dizziness.
Yeah, I think, looking at this, I agree with everything Eugene said. I mean, we've got this uh, pretty significant sized cerebellar lesion
sure.
that's obstructing the fourth ventricle, like Art was suggesting at the beginning, and obvious, hydrocephalus and symptoms that are probably the cause of the headaches and the optic disc, blurring. To me, looking at this, the most urgent thing for this child would be, he needs a shunt or decompression, and then figuring out what the heck the tumor is and what to do about it afterwards. But that, to me, this one almost looks sort of emergent, where I would not let them go very far without getting things taken care of. That's a scary looking lesion, and compression of the brainstem, even more so than the hydrocephalus, I think is the major issue here.
Yes. What do you think about the time it took? This lesion was not kind of overnight lesion, and the patient spent almost about a year going between different places, suggesting vestibular rehab.
Well, I suspect it probably was not obstructing the CSF flow the whole time. That probably gradually developed over time. And so that, probably a lot of the vestibular symptoms were before he had hydrocephalus. And I don't know what the time course for the headache, but I bet you if you asked him, you'd find out he had the clumsiness and the off-balance stuff that preceded the headache is what I would suspect.
Okay.
As the same
Um,
as Jerry told already, I think that it's a very insidious processes, and in this localization, the classical signs there was not they are not focal signs of localization, and maybe because you told, I think that I heard Mo that you told that the boy had a voice a little bit particular. Maybe because the compression would be it is very low located. Maybe with an compression on the indirect compression on the vagus nerve. And we see that I don't, it's possible, but I see that in the cerebellar sulcus are very diminished. I don't see it very well. So it's a very, probably very, very slow and progressive growth.
okay. In your opinion, sorry, Art, did you want to make a comment, Art?
No, I'm just saying like what Jerry was saying. It's interesting. This seems to be an acute presentation of a very slow growing tumor. So something has happened. Maybe like you say, a sudden complete obstruction of the fourth ventricle. There's been an acute. It's an acute presentation, but it's not really acute. Something has happened acutely, so it needs to be addressed right now. Unfortunately, it's been going on for a year or a couple of years, I guess.
Oh, probably more
Yeah,
than that. Now,
yeah.
regarding the timing, what is your experience, faculty, and also comments also would be appreciated. If you suspect it's benign paroxysmal positional vertigo, which is not a diagnosis, as we all know, it's a symptom of something going on. Most of us, at least me, people respond fairly quickly, maybe 1, 2, 3 attempts, but not
Yeah.
60, 70
Yeah.
attempts.
Yeah.
So what are your thoughts about this, gentlemen, ladies, as well?
Sure. So I'm with you, Mo. When I see somebody with BPPV, my thought process is they've had a damaged utricle. And so when you have a damaged utricle, it could be an isolated event like they bumped their head or something like that, in which case you do cannulate repositioning and they're better. But when it happens repeatedly or you fail to make the patient better with cannulate repositioning, you got to think there's something that's causing repeated damage or repeated, you know, repeated damage causing the otoconia to get loose. So in most cases that I see, now granted, I'm in a situation where patients generally don't come to see me for one episode of BPPV, but when they've had it been going on for, years, it's usually there's some other process that's causing it. And I think it behooves us to look for that cause. Now, where's the cutoff where, one episode, how many do you eventually decide it's time to look? And I think the bottom line is that number one, if they don't get better with cannula repositioning, or two, if it's, 5, 6, 7 times, it makes sense to, do
All right.
some further investigation.
Now, my threshold is 3. If BPPV fails uh, the CRP treatment 3 times, then I usually say stop and think about what's going on here. It could be that they're doing the wrong maneuver. I mean, if you do Simon or Epley on a horizontal canal, it probably work. Uh, and that brings the question really who and I know it's political, but for the last 5 years since I started the AVM IB, I've been addressing political issue in connection with vestibular medicine and auditory medicine as well, being trained as an audiologist before I became a physician. Who really should be uh, performing the maneuvers, and should there be a team kind of approach instead of doing it individually because they attended a seminar, webinar, and feel, oh yeah, I can do that. What's the system in France, Eugene, if I may ask?
First, I would like to point out, I think that even in case of BPPV, yes, perfectly agree with you both. If it doesn't work, must think about further to another etiology. Besides, generally, um, even in case of benign childhood benign paroxysmia, between the crisis, the postural control, it's okay. They are not clumsy, the patients. They are quite good. They are not clumsy and slight postural control. So this is a red flag. And to respond to your question, Mo, I think that in France, in fact, if the vestibular physiotherapist didn't understand what's happened, they sent the patient again to the neurologist to see what's happening generally. I saw some exception also, but generally, and at the hospital in our department, we used to see some complicated patient with the physical therapist together. But in general, physiotherapists they practice in their office. So it's a neoliberal practice, and in case they they have some problems with the patient and the things didn't go in the good direction, they sent us back the patients for further diagnosis.
Okay. Jerry?
You know, I think one of the big things we're kind of talking about a little here is something called anchoring bias, which is one of the cognitive biases that's out there. And it's like once you label somebody with a diagnosis, everybody anchors on that and they're afraid to deviate from that. And it's one of the, I think, the universal things when you've got a patient that has a particular diagnosis and the treatment is not working, you need to go back and think, was the original diagnosis correct to begin with? And that's a difficult thing for people to do. And I mean, we're all guilty of it. But even just recognizing the whole issue of anchoring bias, I think helps people kind of, okay, I got to rethink this. And I think the way you put it is, it's like once, if they're not getting better after 3 or 4 times, it's like, okay, what is wrong here? I can't keep beating my head against the wall. Let's figure out either we're doing it wrong or we got the wrong diagnosis.
Yeah. That's so important that's so important to say, Jerry. This sort of diagnosis, you come in and you say, okay, I roll over in bed and I spin for 15 seconds. Okay, you got BPV. Thank you very much. Goodbye. And I'm preaching to the converted here, I know, but it's so important to take a long history. Somebody comes in and says, well, I got spinning and I don't know I think you got BPV, but they failed to take a history. It said, look, 5 years ago, I had an acute attack. I was spinning for a week and I was off work for a month. Obviously, they had an acute vestibular attack. Perhaps now they're decompensating or they've had another little wee problem. And as I know, I've heard Joe Furman talk about this before. It is very, very hard to recompensate. If you have another little event from whatever, it is very, very hard to uncompensate and for what happened years ago and recompensate for your new problem. So that again, like you say, Jerry, you can't have an anchoring bias. You might be right, but you might be wrong. Don't forget that, boys and girls. You have to be careful to make sure that you think outside the box. Make sure you think outside the box.
What is the situation in Canada? I'm sorry. Go ahead, Gerard.
Well, I was going to say, Art, something you just said reminded me of something I was told a long time ago. You can spend a long time with a patient and you think you know what's going on. And then right when you're getting ready to leave, the patient says, wait, there's one thing I forgot to tell you. And that's the most important thing they're going to tell you in the whole visit. And it usually can change all the time. Diagnosis.
Oh yeah. I had Meniere's disease 30 years ago, but that got better. But this time it's just not getting better. And that just tells it. I hear that same story all the time. Like you said, I don't have to tell anybody. I'm sure you guys all hear this. But yeah, in Canada, it takes a while to get in to see a doctor. Everything's free, as you know, but it takes a while to get in to see the doctor. And you get referred to a physiotherapist. Again, sometimes they're quite good, but sometimes again they get an anchoring bias. Okay, if you tell a BPV story, sort of, then you've got BPV. And there are some people who say, well, yeah, like you said, well, if you can't be fixed, then maybe you're just not cooperating or not doing, or you're depressed about things. But you've got to think outside the box. Again, excuse me for talking down to you like medical students, but
that's fine. It's fine. In hearing, we always had this quote unquote red flag. If you have a unilateral sudden sensory neural hearing loss, the patient must be medically cleared before any further intervention. I'm not sure if the same red flag is applicable to BPPV when they go to physical therapists. And I think it is time that it should be treated similar to the unilateral sensory neural hearing loss.
Well,
or use it. Use it diagnostically. If the Epley maneuver works, great. That's what you've got. If the Epley maneuver does not work 3 times, like you said, Mo, that's not what you've got. So it is a
And
diagnostic procedure in a sense.
right, and I don't mean that it's a red flag and should be sent to the ENT, because the average, to be fair to everybody, the average ENT is not comfortable dealing with vestibular medicine, by the way. We all know that.
Sure.
And they don't know how even to do the maneuvers. So I think the teamwork, including the physical therapist and audiologist, is important, but I think the red flags should be made very clear to everybody. Jerry, you wanted to say something?
I was going to say, at least from I can't say this is universal, but I think for the vast majority of referrals I've made to PT for vestibular rehab, I basically have to sign off on their treatment plan. And so, in some ways, that's a little bit of shift of responsibility to me to make sure that this patient doesn't have something worse than just a vestibular lesion. And I think that is a safeguard. I mean, I don't think, physical therapists have the ability to order MRI scans and things like that. And so they're dependent on us to help them and keep them from going down that, uh, the wrong road, so to speak. So it's really, I think, our responsibility to help them with that. Now,
Right.
that said, you go on the internet, I mean, there's tons of videos on how to do canalith repositioning, and I have a lot of patients that do canalith repositioning on their own, and I think that's fine as long as it doesn't get protracted like you're talking about, and I think most people realize that, gosh, I've done this 8 times and it's not getting better. Why the heck am I doing this anymore? I need to go see somebody. So I don't know if it's a huge problem. This particular case obviously fell through the cracks, and uh,
Yes.
it's just
Okay.
so sad given the age and that this kid could have been saved earlier with the shunt.
All right.
Yeah.
So, as I'm sure you all would do, I really called the hospital where I was. It was not a major hospital, and I had to call one of the major hospitals for neurosurgery consult. I felt that something needs to be done urgently. Unfortunately, this kid actually died before the surgery. He went to the hospital, admitted, and the kid died. That's the only patient in my 40 plus years that died because of a situation like this. And I hope this is not the case everywhere. In all likelihood, I think this kid would have been alive if he was initially referred to pediatric neurology, which brings another point. In different parts of the world, auditory vestibular medicine is taught, trained differently. In the Middle East, particularly, the auditory vestibular medicine or audiology primarily is a diagnostic subspecialty, and they get residency, and they are really very well trained on a diagnostic evaluations. But the programs as they exist don't have any clinical rotations or even clinical medicine included in it. It's just like, for example, radiologists, pathologists. So these are some of the issues, again, that need to be addressed. And I'm sure the attention of everybody is taking care of the patients. And what are the lessons, really, at least in my mind, that I have learned from that, like to share with everybody? Really, history and the exam, vestibular exam is very important. Not many neurologists, not many ENT do vestibular exam. And vestibular exam requires that you put glasses, forensic glasses, or video to do the exam. Uh, Generally speaking, the general ENT exam in patients with dizziness is practically normal. Lesson two, the clinical exam plus imaging, particularly, not necessarily with vestibular testing, with imaging, are more sensitive and informative than all the vestibular tests in the world, at least to know that there is, especially if the clinical exam points to central problem. Lesson three makes industry hate me, but that's fine. They hated me even years back when I presented that you can figure out what the ENG test result, or at least 90% of them would be evident on vestibular exam. So unnecessary vestibular tests and rehab really do delay proper diagnosis and treatment. That I would love that we collect all the cases that at least the faculty of this forum have seen. And lesson four, kids should be seen by pediatric neurology when having dizziness. Pediatricians or audiovestibular medicine physicians, when they see patients who don't have any hearing loss, but have any dizziness, vertigo, balance issues, it doesn't take much to get a referral from pediatric neurology, actually. Um, so, any additional lessons that you would like to add to that?
Mo, I would slightly disagree with you on the
No, you can largely disagree with me if you want,
I've
Jerry.
never disagreed with you before,
We
right?
know each other very well. Go ahead.
But you know, I think about vestibular testing, I think is just an extension of and a quantification of our physical exam is what it is. And if it was done properly, it really should have just screamed cerebellar dysfunction, in which case it would just really emphasize, hey, this kid needs an MRI scan, is what I would say. But otherwise, I mean, I agree with you. I think a kid with headaches and dizziness, I think a neurology consult, and I think about all the ones I've seen, I think I've gotten them on every single one of them, regardless of what I find, just because it's just a little more concerning in kids.
Yes, and
Yeah.
the operative word, Jerry, is if done properly and interpreted correctly. The vestibular test interpretation that's automatically put by industry on vestibular tests are not really appropriate. For example, when you do EKG, at least in my area here, if the EKG is going to cardiology or internal medicine to be interpreted, yeah, they put some machine-generated interpretations. But we have to be careful, really, with automated interpretation of biological tests going forward, at least in our area of expertise. Eugene, what you like to add or subtract or comment?
So I'd like to say that if you perform a very good examination, physical examination with an hence a plus, and to add some extra vestibular assessments, and if they are normal, and if the headache is present, and if we say, and if the patient, the young patient, it's not good. Effectively, we do need to get a neurological assessment to demand it. And I think that one problem which generate difficulties and for the ENTs, for the neurologist, and even for the physical therapist, is that we do not explain, we do not emphasize that it's a very it's not very well known that even normal subjects with no symptoms could exhibit nystagmus, positional nystagmus, and now I believe 15% of subjects. And in this case, imagine somebody which had some headache, dizziness, but no real vestibular impairment. We perform some Dixel pike position maneuver, and we observe some nystagmus. And in this case, we insist with some maneuver, even if the patient did not display the all characteristics of an BPPV. And in this case, we don't refer, and there are, unfortunately, like in this case, if we don't refer the patient to the neuropediatrician, we have a result like this one you just exposed it, Mo.
I agree.
Yeah.
A couple of things here. It's a shame that it took a year to do all these vestibular tests. And like Jerry said, the tests can be sort of helpful in diagnostic if you do one set of calorics, and the calorics are reasonable, and you see failure of fixation suppression, that immediately raises a red flag of cerebellar disorder right away. You have to phone Eugen up right away and say, look, this kid doesn't have acute vestibular disease, and failure of fixation suppression, over to you with the first ENG you do. Don't do repeated ones to try and find an abnormality. Just there's something central going on. Even if there was a slight caloric abnormality, it doesn't matter, because a 16-year-old is going to compensate. So the fact that their 16-year-old has not compensated and there's central signs, you have to send it off to it's central. It just is central.
You're making a very good point, Art. Do you know that there are some practitioners globally? I've been around the globe a little bit more than several. They are advocating that the caloric test is no longer needed after the quote unquote the V-hit testing.
It is
I have a slide to explain about that later.
It is helpful, if only because it can recreate. If a patient has an acute story, do the calorics and say, have you, in a non-leading, have you, what does this feel like? And if the patient, this is exactly the same thing, that's helpful. Or if the patient says, no, that's not, that's totally different, that's helpful as well.
Yeah, I'm well aware of this, but my point about the caloric is, for example, I never do gentamicin perfusion on an ear unless I'm absolutely sure that the caloric test in the prone position, not on the supine position, is practically absent completely. Anyway, Jerry, you wanted to say something?
I was going to say, we have a question on the forum from Silvana.
Yeah, can I finish I have one more slide, and then...
Oh, yeah, go ahead. Go ahead.
Yeah. So
one more slide.
I hope the audience share the lessons that I personally learned from this case with your students, colleagues, and everybody else. And I'm practicing my American influence here, a little bit of advertising. Dr. Mucci and I have seen actually a fair number of patients virtually in the last 3-4 years, and it is working. It's working well. And I think even if you are in a hospital, and I'm not talking to physicians, but I'm talking to patients here, and you really have vertigo, and you are in the hospital now for about a week, 10 days because of vertigo, talk to us. Or if you want consult from home, it's been very helpful modality. And I think it's on the rise as well in the United States and abroad, which is good. I think that would help the dizzy patients that have been running around for years. We've seen a patient the other day that 15 years has been diagnosed with vertigo with no treatment or proper diagnosis. All right.
Yes.
Podium is yours, Jerry. You're the boss.
Well, I was going to say we have a question from Silvana, which I think brings up
Yeah,
an
all right.
interesting scenario. She asks, her comment is, great case, great discussion. What about migraine in children as etiology of postural dizziness? And to me, it brings up the whole question of, okay, what are we considering as our differential diagnosis in someone who's got central positional nystagmus, like the kid that you just presented? So I throw that out to you guys. When you see somebody you're suspicious of central positional, or let me broaden it. Let's say it's someone who's got positional nystagmus, but they don't have BPPV. What are you thinking about?
And
You
may I try to answer?
Yes,
So,
sir.
this is if you have now a classical BPPV which respects the gravity and the law of the vestibules, that is not VPPV. VPPV in children also it's a real VPPV. It's rare. So if headache plus dizziness and no positional maneuver to heal the vertigo or the dizziness, you should, again, I repeat it, should try to refer the patient to the neurologist.
Yes.
If I, in my experience, because I have a consultation with the a pediatric consultation. Migraine, it's migrainous terrain could generate some vertigo, could generate some synatosis, but not in case there are a history in the family generally. If not, if of course, if the headache occurs from lately, should perform in imagery or a neurologist assessment. So I think that it's more likely to have adults with migraine and dizziness, but not so it's not so frequently in children. And children, they are there are some vestibular phenomena which is acute, more likely, and when you are not sure if headache and dizziness, again, imagery and refer to the neurologist, pediatric neurologist.
Yeah.
What about you, Mohamed? What are your thoughts? What are your thoughts on causes for positional nystagmus other than BPPV?
Oh, I mean, BPPV is a positional type nystagmus.
No.
Right?
What I mean is, in like for a child, let's say this child who obviously had a central phenomenon going on. Let's say, for example, the MRI, you get an MRI scan, the MRI scan is normal. What would be in your differential diagnosis as the possible causes for his central positioning nystagmus?
I think in the absence of a lesion to explain the nystagmus, migraine or uncompensated vestibular deficit are the two major ones. We also need to keep in mind that calcium homeostasis, including the PTH, ionized calcium access, is very important to keep in mind. So if you have somebody with no migraine, no history of vestibular neuritis, no history of Meniere's presenting with benign positional vertigo, I usually get the PTH, ionized calcium, vitamin D, and look, especially if in women a little bit elderly, look for osteoporosis, osteospongiosis in the ear or something like that. Sometimes you get subclinical conductive hearing loss. I get a CT scan of the temporal bone as well.
Yeah,
What do you think, Jerry?
Yeah, I think all of those are good things. The other thing I would throw out there is in case, certainly as we mentioned, migraine, I would add elevated intracranial pressure in there.
No?
I
Yeah,
would
sure.
add third mobile window disorders. I mean, I've seen some cases of positional vertigo that I think is based on the change of intracranial pressure when you go from down to up, putting pressure on like a large dehiscent superior canal. But another one, when you think about central stuff that I think a lot of us tend to forget about is medications. Especially when you look at the neuroleptic medications, they're kind of notorious for causing some central positional nystagmus. But the other big one
I,
that I agree with you is the uncompensated vestibular loss is a big cause for positioning nystagmus that's not BPPV.
On
Sorry,
that, I was going to say on that line. Oh, go ahead, Eugene.
sorry. I when the asking was posed, I think I thought only to the migraine, the migraine subjects. But you know my position, Jerry. I search in case of isolated manifestation as a BPPV, but it's not a BPPV. I generally search for an even I saw in kid I treated kids with a neurovascular cross compression. We should look after that, or even an near narrowed internal auditory canal. I already published that, and I have some very interesting pictures and radiographic assessment in which channel blockers are extraordinary as results.
I think that's a great addition too. And I had a case of that recently that I think the positioning nystagmus was from the compression. We have another question in the chat from Dr. Tasha Barton. Agreed, great case. At what point do those of you in other parts of the world refer to an eye doctor for an evaluation of the root cause being related to their visual system, binocular vision issue, or for them to do a thorough evaluation of the optic nerves, early intracranial pressure, intracranial problem that may only have a subtle change that may not be obvious in your office? I diagnosed a brain tumor in a 6-year-old child when their PCP did a complete physical cranial nerve evaluation of the office and couldn't find any concerns. So the PCP sent the child to me for evaluation. So I guess the question is, at what point should the patient be seen by an eye doctor? And at least for me, I think number one, if there's any evidence of increased intracranial pressure, I think they deserve a good, thorough exam. Two, if they have some complaints of visual dysfunction, or if I see some ocular motor problem that I can't explain with a vestibular basis, I think those are kind of the two big categories that I would send to my eye colleagues. Mohamed?
Well, I mean, yeah, I agree with you. Obviously, the number one reason for kids to see ophthalmologists is visual deficit that's observed by parents or a school or teachers, something like that. But to get visual disturbances from increased intracranial pressure, it takes time. And I think there are earlier signs of increased intracranial pressure than visual issues. And Eugene, you're probably more experienced than anybody that I know in the audience for that. So And I tell you, I think in this case, the combination of the intracranial pressure and the tumor is what did this patient in. If this patient had just increased intracranial pressure, they probably would not have died at a young at that young age. What do you think, Eugene?
We don't know the nature of the tumor. I
Yes.
think that was not because the patient was dead. I don't think they perform a necropsy. I don't follow it.
No, they did not. There were no autopsy.
And I
I
think,
actually wanted an autopsy done, but I was overruled in a
yeah,
second.
yes, I imagine that. And I think that the prognosis it's linked of the nature of the tumor. I think that is the emplacement, the displacement of the tumor was not very sympathetic for surgery. We don't know.
Sure.
So I I think that even at the moment they would be shunted. The prognosis was related to the histological examination further.
Yeah.
Any other questions?
All right. So if there's any other comments from the group, I have just a little holdover from last month. If you guys are up for that, let me see if I can share my screen here. Let's see. Okay. All right. So we did that. We did that. Just to refresh y'all's memory, we had a case last week of the gentleman who was the boxer who got the concussion and was dizzy afterwards, and he had a left lateral rectus palsy and cochlear facial dehiscence, retrocerebellar arachnoid cyst, probable increase in intracranial pressure, and left uncompensated vestibular loss. And there was two questions after that I thought were worth kind of bringing up. First was Dr. Aaron Gadre, who was supposed to be with us, had a number of comments that I thought were really good, and I wanted to share with the group. And the first was he said he loved how the radiologist used the grayscale inversion to look for the cochlear facial dehiscence. And he said his ex-resident Tyler Schwartz took that observation to another level and wrote a nice paper on its usefulness on temporal bone imaging. And I have to admit, I learned the grayscale inversion technique from Dr. Gadre. And at first I thought, yeah, it's plus minus helpful, but the more I've used it, the more I've liked it. Second, he says, do look carefully at the stapes foot plate as well. And I guess those are cases where there's no obvious otic capsule dehiscence. He makes the point cases of hypermobile and membranous stapes foot plate syndrome that he published can present very similar with delayed presentation after head trauma. And while I totally agree with him there, I find that a little bit harder to make that diagnosis on imaging because the stapes plate is so thin to begin with that it can be challenging. I kind of reserve that diagnosis for ones where I can't explain a third mobile window disorder somewhere else, and then I'll kind of scrutinize the foot plate. He mentions Tullio and Hennebert's test are telling and Vemp's less so. And I think there's some merit to that comment as well. I agree with him. Confounding here is that he had the cochlear facial dehiscence. He mentions after acetazolamide treatment for migraine, exploring and fat grafting the round and oval window would be a good idea, which I would agree with him. He was not a fan of using gentamicin and would consider sac decompression before gentamicin. And then he asked the question about the March length device that I have for looking at intracranial pressure and how it compares with intracranial pressure analysis with regards to the MRI scan. And I think the best way to think about the Marchbanks device, it tells you whether the pressure is high or low at that moment in time, whereas the MRI scan is showing you anatomic changes that are due to prior elevated pressure. So when you think about it, if someone suddenly develops elevated intracranial pressure, their MRI scan is probably going to be normal. You cannot see intracranial pressure on an MRI scan. All you can see is the consequences of elevated pressure. Similarly, if someone's got, empty sella and, dilated optic nerve sheets and other findings suggestive of high pressure, and you suddenly lower their pressure, well, they're still going to have those anatomic findings. So they kind of lag, I think, the actual clinical picture. Mo and Eugene, any comments about that?
I think all these are wonderful questions from Arun. The number one thing that I would say is I would say that endolymphatic sac before gentamicin, the two are totally unrelated things. Endolymphatic sac shunt, we know now it's running out of favor. It was a faith-based surgery more than a science-based surgery. I have seen Ehrenberg, actually spent some time with him, seen almost, I can't remember, but over 50, 60 endolymphatic sac surgeries. What was interesting is Irv used to irrigate a copious amount of dexamethasone and steroids in the ear before or sometimes during the sac surgery. So the gentamicin does something different than the sac does, assuming that the sac actually works. And yes, the point about the acetozolamide is valid. So those are my two comments about our own comments.
Yeah, so I like very much the this kind of. Actually we use it very often, the grayscale inversion, because it's a very good method to try to deal with some possibilities, and to diagnose the peripetrosal variants of third mobile abnormalities. And I like this also, the second item, as this could be interesting to see that there was a hypermobile on the membranous tapes. This was a possibility in this case.
I was going to say, I find that diagnosis, I feel a lot more confident about when I actually see it during surgery, and I can see the foot plate, and when it gets that appearance where you can just about see through it, I feel confident. I'm not as confident about it when I see it on the CAT scan. As far as the sac decompression, Mo, you and I are going to have to agree to disagree on that one.
Okay, that's fine.
Last slide I have for you guys before we close is Eugene had mentioned about in a patient who had mostly left-sided symptoms or pathology. He on the V-hit, he had an abnormal posterior canal testing. Mainly, he had covert saccades. The rest of his V-hit was normal. And he asked me, why was that the case? And I did not know. And I be honest with you, I still don't know. But I put together this chart thinking it might be giving us a different way of thinking about inner ear pathology. And what I have listed here, if you look at this is just this particular patient's test results. And I've listed frequency from 0 all the way down to 8,000 hertz. And as we know, the inner ear will actually respond to 20,000 hertz, but we don't go generally testing beyond 8,000 hertz. And at the very bottom, I've got the audiogram from 250 to 8,000. And if you remember right, was a little tiny questionable drop at 250. So I gave it a score of pathology of a 1. Okay, I was grading the pathology from 1 to 3, if you would. Then we look at the utricle, and the only couple of places we tested was the video ocular counterroll test, which is 0 hertz, and he was abnormal there. And then we did 500 hertz. He was abnormal there, albeit kind of hyperfunctional rather than hypofunctional. And then at 4,000 hertz where he was normal. And then we have the saccule. The only 2 places we could test was posturography, which was normal. And that's, in my mind, a very insensitive way of looking at the saccule, but it is one of the ways. And then at 500 hertz, which was a little bit abnormal, kind of questionably abnormal. Then the most test results we get with the horizontal canal, and we've got the caloric test, which was abnormally at like a 25, 27% caloric weakness, so I gave him a 1. Then rotary chair from 0.02 to 0.64, he was low gain, so he had kind of abnormalities on there. And then VAT, or vestibular autorotation testing, from 2 hertz all the way down to 6 hertz, and it kind of got progressively more pathology or reduced gain on those testing. But then we got V-hit. It was normal on the horizontal, normal on the anterior, abnormal on the posterior canal. V-hit, that vertical channels were all normal. And then, well, except for the very low frequencies. So if you look at this, and I just kind of look at it, with the exception of the horizontal canal up in the very high frequencies, it kind of looks more like a low frequency injury. And I just thought that was kind of a different way of looking at things. And I know it doesn't answer the question as to why he had a posterior canal deficit, but it does kind of show, the other thing I thought was interesting is just look at all the black is stuff that we cannot or did not test for. And there's still a lot of stuff we don't know about what's going on in these ears in these patients that we test. Comments, gentlemen?
What a great way of finishing this off, Jerry.
Yes.
There's so much. Keep in mind what you don't know, because there's quite a bit that you don't know. So think outside the box.
Yeah.
Yes, indeed. Yes, indeed.
Great display here, Gerard.
I still would say that we should not abandon the caloric test, especially in the prone position, because a minimal residual vestibular function in specific patients, particularly Meniere's and also vestibular neuritis, would be better ablated. And the only way that I would feel comfortable doing it is to test the ear independent from the other ear, which is the caloric test.
I totally agree with you. I would not get rid of the caloric test. And one of the reasons I would say is because we have more experience with the caloric test than we do with any of these other types of tests. It's been around 100 years.
I totally agree as well.
Yeah. And it's the other thing.
The calorics are so important because, and like you said, Mo, having a little bit of function, as demonstrated by the caloric test, is way worse than having no function at all. So if you've treated an ear with gentamicin, you might have left them with a little wee bit of function, and that is a red flag. Well, that's why they decompensate, or they don't compensate properly. You can't compensate for a slightly fluctuating balance organ. So if they do have continuing complaints, and give them another shot of gentamicin. Don't touch your other ear. You've still got a problem with that one ear, and that calorics will tell you that.
In fact, if vestibular rehab doesn't work, we must make sure that there is a silent, quote unquote, fluctuating lesion in either ear.
In the other
Absolutely.
ear.
Because
Yeah.
vestibular rehab requires that there is no fluctuating vestibular function.
That's right. Just talk to an airplane pilot. If you lose one engine in an airplane, that's no problem. If you have a fluctuating airplane engine, the pilot says, God, yeah, I can't cope with this. And he just feathers that engine. So that's what you do, is that's what the ENT does, or that's what a gentamicin treatment does. And it's a totally different kettle of fish. Slightly functioning, it's bad. Not functioning, that's not as bad.
One
Yeah.
other thought. Another reason we cannot get rid of the caloric test is because Dr. Barony, who developed the caloric test, is, as far as I know, the only ear doctor to ever win the Nobel Prize. So we can't get rid of it just for that reason.
Yeah, absolutely. We can nominate you, Jerry. You can't nominate yourself. You're not allowed to nominate yourself for a Nobel Prize. But you got a team here.
There you go. There you go. Eugene, you were going to say something?
Yes.
There is a question from one of the fellows that I trained when I was at the Cleveland Clinic years back. It's from Yasser Nafi. Thanks for interesting discussion. And then saying in clinical practice, recurrent BPPV, especially horizontal semicircular canal, we have to think in migraine. I don't know. Are you there, Yasser, to explain why, in your opinion, that we have to think of migraine, even if migraine is not in the history? I mean, migraine can lead to benign paroxysmal positional vertigo in any of the canals. We know that the receptors, calcitonin receptors, particularly CGRPs, are present throughout the entire semicircular canal system. But I wouldn't use that as a sole criteria that to diagnose Meniere's disease. In other words, in the diagnostic criteria of migraine, vertigo, benign positional vertigo, is not really part of the criteria.
Well,
what do you think, Eugene?
I think that migraine could complicate the clinical picture. I don't think that can, as in mania disease. Mania disease, yes, you had an active mania disease. You can have benign BPPV secondary to the a crisis of hydrops with the dislodging of the otoliths in the semicircular canals. But I don't think that it will. I saw some publication which incriminate migraine and which would sensibilize the utricles and the macula of the utricles, and therefore the migration of the particles through the semicircular canals. But I don't think that the physiopathological explanation is very good. But I think that a migraine, yes, could generate some bizarre or atypical nystagmus.
Yeah.
Well, if there's no other comments, I was going to draw the conference to a close. I've really enjoyed this, and I hope everyone else has. And I just want to call everyone's attention to our next conference, which will be Friday, June 6th. And the presenter will be Eugen Ionescu, who is going to present a case of recurrent anterior canal BPPV. Just a comment, I saw some of the visuals for it. It's some great imaging for it. So I'm kind of excited to see that. And everyone is invited back. I'm going to post this video to our new YouTube website that I created this past month. And if there's any questions you have on this case, just post them to the YouTube channel and we'll discuss them at the next conference. Thank you, guys.
Perfect.
Thank you, everybody.
Okay. Thanks again. Nice. Really enjoyed this. Nice to see everybody. See you in a month.
See you. Thank you.